isolation purposes. I'm going to invite my colleague to jump in here with me on this one, because it's really about, at this level, for patient care purposes, converting the data into actionable information. And the 5 points that we've listed here apply to every provider. Everyone that's in this new health reform is going to have to identify their priority patients and coordinate care and monitor and engage patients and make sure that physician support is real time. So do you want to sort of maybe describe a little bit more in depth? So
sure. I'm going to back up just a step too. And the structured data issue sometimes flies past people, so I'm going to bring it back into focus. The expectations for using a health information exchange will be that you have a structured data taxonomy, HL7 right now. And increasingly, it's going to require SNOMED taxonomies and other things. I've not seen a state data system that is built to those standards at this point, and I've seen very few behavioral health, electronic health records that are built to those standards. So there is a train going down the track toward an edge of a cliff of obsolescence that's impacting most state data systems right now. And it's absolutely unsustainable to have data reported using obsolete taxonomies or obsolete structures or obsolete definitions and expect that you can be playing a meaningful role at any level, at the state level, at the local level, in efforts to join these networks. I was in a state last week where the director of the Health Information Exchange, who had been the governor's health IT lead, said to a group of behavioral health providers, there are 2 absolutes. If you're not all care will be delivered in networks within the next 5 years. If you're not in a network, read accountable care organization, you'll be out of business. Second thing he said is, everyone will be reporting to a health information exchange in the next 5 years. If you can't report to and receive information from information exchange in 5 years, you'll be out of business. Those are the kinds of sea changes we're talking about. And to come back to this, the expectations for providing better care, the whole purpose of the Affordable Care Act is for people to be healthier. The expectations really, to an unprecedented degree, require getting information from patients that helps us engage them in care and helps them adhere to treatment recommendations, which involves behavior change, which is what supposedly behavioral health people are good at. But in order to do that, we really need bidirectional, real-time information with really good clinical decision support tools that help support better clinician judgments and better patient judgments. And that expectation for that bidirectional flow of information between providers and patients are written into meaningful use stage 2 requirements. And that exchange being digital, being able to go back. So providers are now in a situation where they're having to look at how do we take what are now going to be obsolete electronic health records that don't have that capacity. How are we going to build portals? How are we going to have messaging to clients 2 ways? How are we going to use clinical decision support? They're looking at that equation. At the same time, in most states, people are saying, got to send in your reporting information. We got to report for the block grant, got to report to the legislature. It's on a completely different track. And I can't emphasize enough how important this issue of ongoing engagement with and monitoring of client status is going to be a centerpiece of what will make or break providers.
So I'll just pop in here again and we'll go back to Dave. Most of you don't worry too much about cost of it, but I can tell you that this is huge. And your partners, as you become part of these networks or you work with these networks, because they will be coming. And I know that I mentioned this yesterday to some of the folks who are here in the room, I think for a long time, the behavioral health has always been the unfortunate stepchild corner. Well, right now, given the fact that everyone in clinical care now understands that behavioral health comorbidities drive up the cost of care of everyone that has any kind of chronic disease, whether it's congestive heart failure, diabetes, or something else. And that the vulnerable populations that you all take care of, that they will be accountable for, are primarily driven by behavioral health disorders as well. So suddenly, you become the Cinderella doll. And the thought that what that will mean for you as you are supported by these networks, to be part of these networks, is such that you need to be aware that managing costs is a big. So they will need to have access to all this data, and they will be keeping track of all of this. They will be doing a lot of internal cost accounting, and they will expect to get some of that information from you too. And they will be developing alternative payment strategies. And you may or may not be able to share in the savings. You may or may not have other ways of working. But this is coming, and it's important for you to be aware of it. So as Dave said before, when you start talking about meaningful use and health information exchange, it will require sending linked claims, linked quality data through some type of a health information exchange for a number of different purposes. Quality measures will be applicable to everyone. You're not going to have one, just part of your team. And you'll be, again, linking the claims and the quality data to make sure that everything's going. So we'll come back to some of the changes that we're anticipating as a result of the work that's been done by the work group that I've been sitting on all summer, and the meeting we had last Thursday. But I really think it's time to jump in and get into the weeds.
Yeah, there's two points I want to make, and I'll talk some more about quality measures in just a second. The second is this issue of flexible and scalable technology. And, I think from the provider perspective, the notion of having a electronic health record is kind of presumes that, we'll buy this thing and then we'll keep it for a long time. And what's coming in the way of increased expectations around structured data and around the ability to add capacity for bidirectional flow information means that owners or leasers of electronic health records will continue to have to make massive changes to scale up the functionality of those tools for the next 5 years. Not at some point during the next 5 years, but continuously for the next 5 years. And that's got a lot of implications for state systems. Big implication, though, is in terms of how this information flows and what's in it. And providers will need to be using continuity of care documents that now for stage 2 are based on the clinical document architecture. So it is HL7 standard. There will be expectations that those kinds of transmissions occur if you're in a network. And as I said earlier, providers are going to have to be in networks. The accountable care organization is going to be the center of the universe in regions around the country for the delivery of care. So if behavioral health providers can't connect, share, using a health information exchange, they're kind of out of luck. Doesn't make sense for them to be doing separate data entry, separate reporting to state behavioral health agencies using non-structured taxonomies. Is that a feasible business model for them going forward? And I don't think it is. So this is it. The data systems, as they're presently configured, won't survive. They don't add value to providers. They don't accommodate capacity for developing and managing payment reform. The data oftentimes isn't timely, and it tends to be unidirectional. Most of the places I work, the data goes to the state. Sometime later, maybe it shows up on a website or report, but it's not timely. This is the same thing Medicaid's dealing with. as they try to translate an MMIS system that's all the data is 60 to 90 days old into something that allows for real-time decision. They're not aligned with structured data taxonomies. They really don't help the Medicaid agency inform policy change. And there's a changing role here for state behavioral health agencies I'm back to. They tend not to, at the present time, most state data systems aren't interoperable with all payer claims databases. They don't receive that information. They're not interoperable with health information exchanges. Some states actually have access to Medicaid claims data, which is a gold. And ultimately, it's not just a matter of collecting the data and periodically producing reports. It's really a need to reconfigure the capability of state behavioral health organizations so they've got some real analytics. And small states have a hell of a time with that. Even large states do, but it's a different kind of analytic horsepower that's now needed. You're really trying to inform improved clinician decision-making and better strategies for managing specific disease groups. The use of registries, the use of other clinical decision supports are really what's needed. The challenge is that not only are we not there, but the place where that's going to be playing out in many states, particularly Medicaid expansion states, is through Medicaid policy. Behavioral health agencies, and all of us here have heard the term state mental health authority or single state agency on the substance abuse side. And those things can be defined on a very broad continuum. At the narrow end of the continuum, my role as a state mental health authority or as a single state agency is I manage the money that gets appropriated to me. The other end of the continuum is my role as a state behavioral health authority is similar to the role of the state health authority that is interested in the well-being of all the citizens of that state. So there's a changing role here for state behavioral health authorities where you can inform Medicaid and other payers, public and private, about what constitutes good care. But that's a lot more granular kind of information saying you should do supported housing, you should provide illness management. It's not just saying you should use best practices, it's saying here's the data that supports policy change. Here's how that relates to the payment reform, and these are the tools that clinicians can do to better engage in clients adherent treatment. It's a very different game. There's a whole set of measures now that are going to be part and parcel of the reality for everybody participating in these networks, and increasingly for people in the Meaningful Use Program, Medicaid, and those measures, while now disparate, falling across several different domains, are increasingly getting this confluence of support for a single set of measures. And I think private insurers are starting to look at what Medicaid's requiring. The measures that are required for meaningful use are starting to align better with the CMS measures. So you've got, I'm not going to go into any of these details, but right now, health home quality measures get at these sets of issues. And for many behavioral health providers, we've not collected or used this information. We have not really talked about dealing with, so there's a lot of mental health providers that don't really deal very adequately with assessing and intervening with substance use disorders. And not just addictive disorders, but abuse issues. There's a lot of people on the behavioral health side, that have addressed high blood pressure, BMI, smoking, other kinds of risk conditions. National Quality Foundation has endorsed a set of behavioral health quality measures. If you look down this list, you'll see that there are some that are disease-specific, schizophrenia and bipolar disorder, but the expectation isn't that you just collect this stuff. It's that you've done something to intervene with these issues once you've identified a risk. So, the stage one meaningful use is, have you screened people for this? Yes or no? Say, yes, I did, 20%, 30%, you pass. Stage two, it's have you screened people for this, and as a result of what you found out, have you done something? And when it comes to stage three, it's going to be, have you screened, have you done something, and has what you've done yielded a better outcome? CMS and ONC have endorsed behavioral health measures. So here's the set of measures that are now out there that are being used by managed care organizations, they're being used by accountable care organizations, and still, for the most part, state behavioral health agencies, SAMHSA, are requiring a completely separate set of measures, written to completely separate definitions, using completely separate taxonomies for exchanging information. So that's not sustainable. And what I advise people to do in the behavioral health side is start aligning your measures to this, because that's where the action's going to be. And there's a few other measures, obviously, that are important to behavioral health populations that get at housing and employment for adults and get at school performance for kids. But beyond that, what we really want is to manage health. And if you manage health, then a lot of those other kinds of things start to fall into place. Shoot.
Well, I hope we didn't totally discourage you. And we've been in the weeds for the last few slides, so I'm going to put this out a little bit and talk a little bit about the future. As I mentioned to you earlier, we've had a lot of discussion this summer in this work group. And I'm just going to share with you some of the other folks who have been in it. I've been in it because I've spent a lot of time in multiple settings, healthcare policy in Washington, in the IT world, chair of the certification commission that oversees certification of all of the IT to specific standards to make sure it has. I've been sitting on our state in Massachusetts, two councils that have been driving healthcare reform, both in terms of quality and IT, for the last 5 to 8 years. And I'm doc, so I've had the opportunity to really bring a lot of different viewpoints to this ACO work. And it also includes Dr. Wesley Clark, who's, as most of you probably know, the head of SAMHSA. It includes someone from CMS who's very much engaged in a lot of the CMS policy divisions. It includes some folks from ONC, of course. And then it includes a lot of providers who are in this particular arena, including one that has an integrated behavioral health, physical health system. So there's a lot of input that's come in, a lot of people. And last Thursday, we did have another 30 people giving us more input. But it aligned very much to what we already thought. So what you will be seeing coming out of this work group are a set of formal recommendations that essentially meet some of these objectives and a few others that I'll mention as well. First, and probably the most important, is going to be the alignment across all of HHS with respect to quality measures. They've mentioned that there are some issues between, it's not just SAMHSA and CMS, you throw HRSA in the mix. I mean, everybody has their own way of doing things. So the agreement is that they have to align. The second thing is that they also have to align with what's going on in the commercial payer environment. Because at some point, when you are dealing with commercial payers, you do not want to be dealing with pay measures. They're different from the ones in the feds. There are a lot of different ways this can happen. It will probably start with the feds, whether or not they actually go to developing a central database where all the measures get reported. Everyone can just see them. You can pull out the ones they choose to look at, whether it's a commercial payer or whether it's SAMHSA or whether it's HRSA, it's CMS. But that alignment is well on its way. There's no more appetite anymore for dealing with the administrative having to provide multiple sets of measures for the same thing. The third point, I think, is one I made a little bit earlier, and I really want to emphasize. Delivery system is under a lot of pressure as time goes on, the pressure is going to be greater because you're going to have to be making changes as well. So the last thing in the world you need to do is to be spending a lot of time scrambling for data outside business practices. So the concept here is to ensure whatever you're reporting, whatever you're measuring, isn't just for the sake of reporting because some third party wants something. It's because it helps either deliver the care for an individual patient or will help you by getting information back to you about the priorities of care, about programs you might want to implement, about any type of improvement. So I think that's where your program fits in on. I think that's where a lot of other programs fit in, but it has to be for those purposes, for the ability for you to improve your care. There's been a lot of talk recently about patient-reported outcomes. AHRQ, if you haven't seen it, has developed, actually it isn't AHRQ, it's the NIH, National Cancer Institute, have developed a set of patient-reported outcome measures that are being used right now for research purposes. But that data set, which has been validated and is, as I say, in use right now, is being looked at very closely by the National Quality Foundation with the idea of pulling out a subset of patient-reported outcomes that would be most valuable to both patients and in the delivery system. When you go there, you will be overwhelmed by all the assessment tools that we have. There isn't a patient on the face of the earth that would go through all of them, which is why they're going through that process, and they've been working on it for over a year now. So we hope getting some patient-reported outcome measures that everyone can use in their own particular area in the not-too-distant future. Dave, I think I'll pop back to you now for this one.
So what we've been talking about, and this schematic kind of shows, is, we talk about integration. Everybody's got their own definition of it. But what increasingly is coming clear is that it's knowledge and information integration. And, we've got our traditional legacy information we collect in clinical records. We've got now an increasing expectation for patient-supplied information about lifestyle, attitudes, willingness to change, readiness to change.
Can we assume the arrow's going in the wrong direction?
Yes, you can. And you've got that information flowing into and through EHRs and portals, but bottom line is that you apply all that, you start to come up with individualized recommendations. So I'm going to talk about the fact that key decision makers often think about the changes that are a result of high-tech and health information technology as technology. And I've called commissioners around the country and said, I'd like to talk to you about health information technology issues. They say, let me transfer you to my IT guy. Because they don't see this as a key set of policy and business decisions.
Oh, wait a minute. I'm sorry, I have to interrupt here. You've got the wrong president.
I know.
You were supposed to change this. The reason I'm jumping in here is I happen to be, let's see, back in 2004 when it was first being developed, and it was George Bush's executive order that said everybody had to have an EHR by 2014. This is the president that put everything else in place that said the EHR has to meet all these needs, it has to be interoperable, you have to have HIE. He basically said you really need a robust, interoperable HIT system. So we're going to have to change the slogan.
Okay.
You promise? You're my
I hate to put
witness.
pictures of George Bush everywhere.
Just add the words robust, interoperable to that one and you're covered.
So, kind of pivoting now to how do you get there? And you can't not design this. The need for states and local providers to do a readiness assessment, a detailed readiness assessment, is absolutely essential. And it's very hard to get that moving. And I'm going to criticize commissioners here for the next few minutes, but I think there's other key decision makers in the legislature, in health and human service umbrella agencies. They're guilty of the same kinds of things. You don't have to understand programming to understand the importance about technology and how essential it is to sustainability of the value of not only state agencies, but local providers. The willingness to press and support provider change is oftentimes something commissioners are uncomfortable with. They're oftentimes not engaged sufficiently with Medicaid around future planning and bringing value to that conversation around what we can tell you about behavioral health populations. In many, many cases, they've not been involved in health information exchange planning. And, you know, and in many cases, they've sent the IT guy to go to those policy meetings. They're important policy meetings that the commissioners that bring some, you know, emphasis around the policy issues have been disconnected from. And, you know, they tend to say, well, we don't have a budget to change our IT system or our MIS, so there's no sense in talking about it. And that is a huge mistake, because it is essential that you, as a state agency and as a local provider, do a detailed needs assessment. When we do talk about readiness assessment, there's the fact is we talk about health reform readiness, and there's a lot of people out there providing consultation services on health reform readiness. And a lot of people doing presentations that in different ways describe the Affordable Care Act to people. That the fact is you can't think about health reform without also assessing organizational capacity and your health information technology. Those things are inseparable. They're woven together tightly. So it doesn't do you any good to say, well, look, we're going to understand the Affordable Care Act unless you understand these other facets. And really putting in place a roadmap for your organization, state or local, for the next 3 to 5 years. And I'm going to go through this really quickly in the sake of time, but there's a maturity model for patient-centered health IT. And a lot of folks are kind of here now. You've got patient, we collect self-reported patient information, which we collect through assessments or other things. And that's kind of where it stops. And what we're going to need to do is move through or jump to the last step here, which is level 5, where we talk about a very interactive system. It gets information, supplies information to patients, gives them tools, gives them educational materials, gives them things that help support their adherence to treatment. And that level of maturity is what we're now facing. And there's not a lot of people in the primary care space that are there yet, but there's a lot of people that have been working for 3 to 5 years to get there. When in many cases, behavioral health folks have said, well, we're even started. I was in a state last week where 75% of providers in the state said we haven't done anything to get ready. But this is a state that's doing Medicaid expansion starting in January. They've not done anything to get ready. So how complicated is it going to be to manage this change? Well, it's pretty complicated. And I think it's really important to do it anyway. And one of the things we've been involved with is creating a matrix of issues in the organizational capabilities that are needed. You can drill very specifically into the gaps in your system, the threats to your system, the opportunities. And it gets at these issues of, governance, whether or not you've got measurable milestones that relate to these very specific issues, your financial capacity to invest in technologies, and also to get a better sense of what your workforce demands are. I'll speak to state agencies right now that oftentimes don't have people with the skill sets that are going to be part of this new world order. And state behavioral health agencies have for a long time had people that are specialists in certain types of programs or populations. The demand for analytics is going to be huge, and the demand for people to be able to manage payment reform is going to be huge. That oftentimes hasn't been on the front burner for folks. So what we look at are the vulnerabilities around payment reform, data integration, data exchange, process improvement, and culture change. And it's a very detailed assessment tool that we've got that does that. So kind of getting toward the end here, and basically I think this is some questions to ask about the data system we've got. Basically what's out there now is not going to be sufficient, and you need to align with the kinds of quality measures and reporting requirements that we've been talking about during this hour. This ongoing need, yes?
I had a question. Do the health homes have, when they were rolled out as a concept, did they also include standards? It would be like something like a fidelity scale that would appeal to see if their ACOs are working correctly.
Health homes, well, the thing that's important to know about health homes is it was a pilot. It's a pilot that's in. So what's happened in a lot of states is that they've said, well, we don't know what to do with behavioral health, so let's create a behavioral health home. And in many of those cases, they haven't done the level of risk-based contracting that will be increasingly a part of the accountable care organizations.
It's also supposed to be incentivized as well, right?
You're supposed to be incentivized, so it's really kind of the primary care medical home where you're giving extra money for case management or care coordination, but in many cases not at full risk for things. And I've seen great unevenness in states about the extent to which they really have expectations for seamless integration of care. So it's been kind of, as we all know, we've built walls around people with mental illness, substance use disorders for a long time. It's like another wall around these folks. As they start to fall into Medicaid coverage, as some for insurance, with behavioral health benefit, they all have the ability to take the new safety net will be that insurance. And so they're going to be able to take that to other places, and accountable care organizations will be the networks where things start to gravitate. So these are questions I think you've got to ask yourself about your data system and about your readiness. And when we think about that, in particular, information strategic planning, there's a set of questions that I think you need to ask. If the answers are yes or no, it helps you kind of know what the next steps are going to be. So we've been working with Colorado for a while, and Colorado is one of the states that is all in on everything you can possibly do with health reform, which is really exciting, but at the same time frightening. And we've been working with John Mahalik, who's got the lead on a data integration project that takes the long-standing mental health reporting system, the long-standing substance abuse mental health system, reporting system, and says, let's integrate that into one. And so we've done that, and their vision for this is that it doesn't make any sense to do it if it doesn't interoperate with health information exchanges, because we want to be part of that connected system. And so what they're doing is utilizing what SAMHSA created as a draft continuity of care document that's written to HL7 standards as the crosswalk from these previous data elements into a set of data elements that fit into the framework of a health information exchange, which I think is very forward thinking. And it puts them in play with Medicaid expansion, accountable care organizations, with health information exchanges throughout the state, because now they can start to share information. And it's a huge, powerful step that they're taking toward that adding value around behavioral health to all the issues that go on in Colorado with health reform. I love this slide. I said yesterday, I think I'm going to get a tattoo of this slide because it's this Joel, who is the MMIS lead for their re-engineered system, came up with this vision for their data, the data strategy for Medicaid in Colorado. And and what it jumps out at me about this is this progression from claims and encounters and assessments where most people are at now. This is where we stop. And what they're looking at is how do you start to pull in all this other information? How do you start to clinical registry information, public health information, other social service agency information, child welfare, education, juvenile justice, adult justice. How do you start to pull this all in so you can start to do predictive analytics? And that is the vision for the Colorado future. It needs to be everybody else's vision too. Because you can't do predictive analytics, you're not going to add anything. And there will be people filling that space, and increasingly there'll be people filling that space for behavioral health. We were just looking at a news release yesterday where New York has released $50 million to add behavioral health capacity to FQHCs. Not to the state mental health and substance abuse agency, to FQHCs. So, you know, if we think we can continue to sit where we've sat and have a future, I think it's sadly mistaken. So bottom line, and your data people will appreciate
Having our big discussion around quality measures. There are a couple more that I just wanted to share with you before everybody pops off to lunch. And one of them has to do with the increase in data availability. There are ways, and there is a recommendation coming forth that will increase access to behavioral health claims and technical support for state all-payer claims databases, certain data in that way. Also, there's a recommendation coming forth about increasing data access through ADT fees. And for those of you who might not be aware of those are the admission, discharge, and transfer information. So that if one of your patients suddenly shows up in an emergency room, you know as soon as they register that they're there, which is critical for you. You want to know that sort of thing. There is also going to be a recommendation around increased data access through integration of the social determinants of health at the state level. And then we talked a little bit already about the quality measures. And then there are a number of ways that behavioral health and physical health programs can be integrated going forward. And instead of having these separate pilots on home health and then the ACOs, all of the requirements that are important for continuity of care will be included in those. And probably the biggest recommendation that's going to be coming from that is that everyone adopt a longitudinal shared care plan, which has been balloted right now in HR 7 and will be worked through and looked at in the federal space before it becomes available. But it will be a way that you can share online in the care patients that require not only your care, but behavioral health, mental health, substance abuse side of it, but all of the physical care that's also important to the patient. So those will be coming. So we will get there. When we got there in Massachusetts, it took us a long time, but we will get there as an entire nation. But it will require your help and require you moving forward. So everyone's going to have to contribute. You and your team will have to understand a whole bunch of things, which we'll list over here. And as Dave said, if there are any questions, we're both available to answer them, and the slide set will also be available to you.
So, which definition of social determinants of health are you referencing?
It's being worked out. We're still at the work group level saying there has to be a group that's going to be formed to really create those.
Who's the sponsor of that group?
It will be the federal government. They will bring together some people, but they will bring people from the outside. It will be something very similar to our work group. And I know that there are other organizations, some particularly in public health areas that are contributing. And if you would like to be part of that, and just give me your card or your name, and I will.
The two states that you all know, what do you think the future of the state mental health authority is, of Massachusetts or Texas?
You know, I think I'm not very optimistic about Texas because there's so many barriers to doing the right things, and a lot of that's politically motivated. That the things that will happen without support from the behavioral health agency, and providers will be out doing things that they think make sense. But the things that they think make sense is doing things the way we've always done it.
So basically, this will all roll over the state mental health authority in Texas.
Yeah.
And the providers will operate outside.
Yeah, and there's some that'll do a good job, and they're already affiliating with the people that are going to be the accountable care organizations. There's others that won't get there. But, you know, I think there's going to be a lot of shakeout in behavioral health agencies, and it's one state I'm working in, well, actually several states I'm working in. You know, the recognition is starting to dawn that some of the providers we've got aren't going to be providers that are going to make it. They just can't sustain. don't know about Massachusetts.
Well, Massachusetts is a very different model. It's similar to, I think, many Western states in terms of maybe size. We have about 6 million people. I think Colorado has about the same, and it only has a little less than 1 million, but we're relatively small in terms of overall population. We do have, however, a pretty structured approach. Everyone is under the Secretary of HHS, including the authority. And the push from the governor and from used to be Judy Ann Bigby and currently is John Polonowitz, is very much in the direction of health reform. We have legislation in place that says everybody has to be in accountable care in the next 2 years. So this is going, and the authority actually is at the table. You know, they sit at the same HIT policy meeting that I sit in, that's chaired by our secretary, with the idea that there is going to be change, but the authority is going to help them get through it. So they will be partnering with, and there will be change, but the authority is there to help them basically get through it.
There's a question back here.
Yes, a couple of things. You said we were going to get the deck, the slide deck. When?
Good. Jeremy?
Jeremy has one.
Can we, Jay?
Yes, I mean, I can, I'll send out all of the presentations that we've had over the last 2 days.
Can I get a copy of this deck today?
I think I can, yeah, if you just give me your email.
Well, the reason I'm
address.
saying is because I'm going into a meeting Friday. It's all about this. So I'd like to come kind of prepared, if that's possible. I've never been, well, I can't use that because I have an iPad and it doesn't have a little.
Just
Too
take
bad.
it. It's the only presentation that's on it.
So it just seems, so I'm new to the position, and it just seems like that, coming out of the gate already behind. And it seems like if you go to sleep at night, you wake up and it's like, it's the next thing, and you got everybody that's got an angle on this is what you need to do, this is what you need to do, and who do you believe, and who's giving you the correct information, and how do you act on it to guide things along in the most responsive way. Is it just, because I feel like, you know, I'm here now and I'm thinking everything I thought I knew is wrong.
Oh, good. We did a good presentation.
That's comforting.
You know, I'm in Austin, and you know, Austin, the large charity hospital there hired a vice president for transformation 3 years ago. And they set themselves on a path to do a lot of the things that were in the Affordable Care Act, but that they realized they needed to start on then. And the charity hospital there has about 450 beds, obviously all the usual multiple specialties. It's a level 1 trauma center. But Austin is, University of Texas in Austin now is going to get a medical school in the next 5 years. That's going to be up and running. And so the plan is to tear down the hospital, build a new one that will be a state-of-the-art teaching hospital. The new hospital is going to be 220 beds. Now, there's 1 million people in the greater metro area in Austin, and they're tearing down a 450-bed hospital. They're putting in a 220-bed hospital. You know why? Because they have transformed the way they deliver care, and they've improved care coordination, and they're keeping people out of the hospital, and they're treating people at home using home monitoring and telehealth and other tools. It's a transformed environment, and those kinds of things, it's a big, large bureaucracy, but they have turned that around and are pointed toward this future that is very, very dependent on the use of data and making better decisions about individuals' clients' care. And there's no question in my mind that behavioral health agencies, the behavioral health provider systems can be twice as efficient as they are now. No doubt, twice as efficient. But they're gonna have to, get the launch pad and take off in order to get there. It's not just gonna happen. And that's why those readiness assessments are so important.
So do you call that like cowboying up? get coupled up.
That's one way to put it.
Thanks, I
Thank you.
appreciate it.
Thanks, everybody.